Hello, welcome ladies and gentlemen to today's tutorial. Today we are going to learn about the scalp. Now the scalp consists of some layers of tissues, actually 5 layers of tissues that overlie the cranial cavity. Now this scalp, usually you tend to find people suffering from dandruff as a result of frequent, shedding or desquamation of, the dead cells, actually the cells that form the skin around the area. Now this scalp, yes, I told you that we are going to have 4 layers, but actually, 5 layers, but actually the 4th layer, which is actually made of loose connective tissue, areola, yes, is going to represent what we call the danger zone or the dangerous area of the scalp. Yes, because it represents, the site where infections can actually spread to the meninges, of the brain. Now, because of its area, then it tells us that it will be related to what we call the calvarium of the skull, or the cranial vault, or the skull cap. So, without much ado, let's begin our journey looking at the scalp anatomy of the scalp. Now, as I indicated, yes, if you go and watch the video that I've done under the skull, you get to know that the calvarium will consist of 4 bones only. Okay, anteriorly we are going to have the frontal bone. Yes, posteriorly we are going to have the occipital bone. Then on either side, laterally on either side, we are going to have the parietal bones. So these ones are going to form the skull cap. And this area, the skin, the layers of tissues that we find over here will represent what we call the layers of the scalp. Now, if we look at the scalp is going to have 5 layers, as I told about. Now these layers are going to be with the mnemonic, simply using the mnemonic scalp itself. Then S is going to represent the skin. Okay, so the skin will be related to the scalp. Okay, the skin will be there. And we know that skin will contain, hairs or hair follicles will be present, as well as, of course, sebaceous glands, and of course, sweat glands will be present. Now, because there will be sebaceous glands, then this area, okay, the superiormost area or the most superficial area of the scalp, that's the skin, will be susceptible to what we call sebaceous cysts. And these sebaceous cysts, yes, will form under the skin over here. And what is going to happen is that usually they will tend to resolve, with time on their own, naturally. So that's the first layer that we are going to find. Now, beneath that, okay, we are going to find the next layer. Okay, so beneath that, okay, so there's the skin. Now, beneath that, we are going to find the layer. So we are using the mnemonic scalp, S for skin. Now, C for connective tissue, this time around, which is rich in what we call adipose connective tissue. So, C for connective tissue, actually dense adipose connective tissue. Okay, we are going to find that one here. Actually, dense connective tissue, which is rich in adipocytes, okay, will be present. Okay, and this one will actually connect the skin, okay, to the next layer that I'm going to talk about. Okay, which is actually the gallia aponeurotica, or the aponeurosis, okay, of the epicranium. I'm going to show you that. So that is one thing, is going to serve as that connection. Now, over there at this connective tissue area, okay, which is this one, is highly actually vascularized. Yes, of course, because it's connective tissue, it is also highly innervated. Now, because of its high vascularity, yes, and again, these blood vessels are tightly, okay, or they are actually adherent to the connective tissue. The blood vessels, which is in the next layer, the second layer, which is dense connective tissue, actually rich in fat, will actually be tightly bound to the connective tissue. As a result, what happens is that if there is any laceration, if there's a cut, okay, through any of these vessels in the second layer, the connective tissue area, then what will happen is that there will be, less ability for these vessels to vasoconstrict. Okay, so it tells you that there will be a lot of blood coming out. So it means that if there is a cut, okay, laceration in this, vessels around the second layer, then what will happen is that a lot of blood can actually ooze out from that individual's, scalp. Okay, so that's what is going to happen. Now, one thing that is going to happen again is that yes, we are going to find another muscle, some group of muscles which we call it, it's just a single muscle which is having two bellies, the frontal belly and occipital belly. That's the occipitofrontalis muscle. Because of its pull, its action, it's also going to help in more blood oozing out, from this area. Yes, in addition, what will happen is that around this area there's actually great anastomosis. Okay, so it means that when there's laceration, then a lot of blood can actually come out. Now, one thing that we have to actually know, which I'm going to come to the next one, which I'll show you, is that the bone. Okay, now you can see this bone. I'll be coming to it soon. Now, this cortical bone, okay, which is actually bone of the skull, over here. What will happen is that if there's bleeding over here, okay, and then blood is not reaching this place, then what will happen is that this area will not suffer from what we call avascular necrosis. Okay, because what will happen is that its blood supply will actually be coming from what we call the middle meningeal artery. Now remember that the middle meningeal artery, yes, will actually be inside, okay, will run internal to bones of the skull. Now over here, clinically very important is that we have this weakest point of the skull, which is known as the pterion. Now the pterion will actually consist of 4 bones. These 4 bones will actually be what we call the greater ring of the sphenoid. Yes, we also have what we call the frontal bone. We also have what we call the parietal bone will also be related to it. Yes, then of course we also have what we call the squamous part of the temporal bone also being related to it. Now it's forming this kind of H-shaped structure over here. Okay, and that's the weakest point. Now if this middle meningeal artery becomes lacerate, if there's cuts to it, then there is the need for it to be ligated, otherwise there will be intracranial bleeding, okay, over here. Now for you to go through it, then we have to create a small hole over here, surgically. Now an expert is supposed to do this, so that you can enter in the internal aspect of the bone, so that you can ligate what we call the middle meningeal artery. So that's one thing that we have to know. Okay, now the next layer, which I'm going to show, we've seen the skin, we've seen the second layer being the connective tissue, dense connective tissue rich in fats. Okay, so you can see this yellow area. In fact, a lot of fats, you can find it over here. Then the next thing that we are going to see is what we call epicranial aponeurosis. Now we are still using our mnemonic. The mnemonic is scalp, and it's C for skin. S for skin, C for what we call the connective tissue, actually dense connective tissue rich in adipose tissue. Then A for epicranial aponeurosis is the aponeurosis. Now usually the aponeurosis, you can also call it gallia aponeurotica. Now this gallia aponeurotica is actually going to connect. Now you can see there is this muscle over here. Okay, you're supposed to have another one here. Then we also have that which is also oriented posteriorly. Okay, so this muscle, they will be connected. Okay, so by way of having that kind of connection, okay, they will be connected what we call anteriorly by what we call the okay, so usually we are going to have something like this. Now this is the frontal belly of the occipitofrontalis muscle. Then we have what we call the posterior belly, which is the occipital belly actually of the occipitofrontalis muscle. Now they will be connected, okay, by a very strong fibrous connective tissue, where is a broad flat form of tendon known as gallia aponeurotica or epicranial aponeurosis. So that's the epicranial aponeurosis going to form the third layer of the scalp. Now this epicranial aponeurosis will also be relevant. Okay, we can't really appreciate it here, but it will be relevant to also give some attachment to what we call the auricular muscles, okay, to give some attachment to the auricular muscles. You know, apart from that, to what we call the temporalis muscle. You know, the temporalis muscle will also find some attachment, you know, to it, okay, because it provides, you know, this kind of, you know, will give it, you know, some kind of attachment. Now, so the next layer which we've seen, yes, that's the epicranial, the epicranium. Now, this epicranium will be important in giving protection and mobility to the scalp. Okay, epicranial aponeurosis will be important in protecting. Yes, apart from that, give some kind of mobility to what we call the scalp. So that's the epicranial aponeurosis. Now, having talked about the epicranial aponeurosis, I've indicated that, you know, we are going to have what we call the occipitofrontalis. It's going to connect these kind of two muscles, two bellies of a single muscle, known as, you know, there's occipital, the frontal component of it. Then we also have what we call the occipital component of it together, connected by the, epicranial aponeurosis, or the gallia aponeurotica. Now, what we find is that for actually elevation of the eyebrow as well as wrinkling of, you know, the forehead, then it will be by, you know, the contraction of the frontalis component of the occipitofrontalis muscle. Then for retraction, it will be by what we call the occipital belly of the occipitofrontalis muscle. So that's one thing that we find. Now, the next layer that we find, okay, now you can see this is the bone, but just before you get to this bone, then just superior to that bone, the layer that you find is known as, you know, the layer which you are going to find is known as a layer of loose connective tissue. That's areola. Now remember that we are still with an mnemonic, okay, scalp. We've seen skin, we've seen dense connective tissue rich in fat. We've also seen epicranial aponeurosis being A. Then we've also seen actually this one that we are seeing now is the loose connective tissue, loose L, and loose connective tissue specifically we are looking at the areola connective tissue, areola. Now what do we see? Now this areola connective tissue is actually thin, and it's of course going to separate what we call the gallia aponeurotica from what we call the periosteum, which we find here, which we are going to come to, okay, separating these two. Now over here is where the clinical importance comes here. Now this is where we call it the danger zone of the scalp, or the dangerous area of the scalp. Why? Because what happens is that this area is well endowed with blood vessels. Now most of these blood vessels are emissary veins. Now if you talk about emissary veins, we expect that veins are going to be endowed with valves, but emissary veins are valveless, so they don't have valves. Okay, now they don't have valves. Now these emissary veins will actually connect. Okay, now if you look at this, okay, now this is the cortical bone. Now you get to know that we have the outer plates of the bone, then we also have the inner plate. In between them there will be what we call a spongy layer known as diploid. Now this diploid will contain some veins known as diploic veins. So what we are saying is that the emissary veins, which are found in the fourth layer, the loose connective tissue area, areola of the scalp, will actually have some connection, okay, to what we call the diploic veins, as well as, you know, intracranial, venous sinuses. Importantly is this sinus, large sinus that you find here, which we call it superior. This blue color, its color structure over here is known as superior sagittal sinus. So that that is what is going to happen. So that what is going to happen is that, yes, this area will have a lot of blood. A lot of blood will go through it together with pus. Of course, we talk about pus, we are talking about white blood cells. Okay, yes, especially infected state. Then we talk about that thing. So blood and pus can spread easily within it. Okay, in the loose connective tissue area, can spread easily, through it. And then what happens is that if it spreads through it, they were able to pass into what we call the cranial cavity. Okay, along what we call the emissary veins that we talked about. That's, of course, the infections can actually spread, from the scalp to actually what we call the meninges. So actually, yes, what will happen is that if you look at this, there's actually what we call false cerebellum. Now this false cerebri will actually serve as a partition. It's actually extension of what we call the dura mater into what we call the substance of brain, trying to divide it into two hemispheres. Okay, of course the corpus callosum. So when we look at the brain, we will talk about all those things. Okay, now so it means that infections which are in the loose connective tissue area can ultimately spread to what we call the meninges. True, of course, we said that we're going to have emissary veins which are valveless. It means that yes, everything can easily flow through it. So they are valveless. That's one thing. Then they will connect to what we call the diploid veins. Then from diploid veins together with also what we call the superior sagittal sinus, the infections can actually spread to what we call the meninges of the brain, leading to what we call meningitis. So that's one way. That's why we call the fourth layer, the loose connective tissue area, the danger zone of the scalp. So that's one thing that we are going to see. Now with the lymphatics, with the lymphatic drainage of the scalp, what happens is that yes, we are going to have two. You can divide it into anterior and posterior component. So that what will happen is that the posterior half, the posterior half will actually be drained into what we call the occipital. Yes, the occipital is the posterior aspect. Occipital, nose, as well as posterior auricular nose. Okay. Then of course the anterior half will actually drain, into what we call the parotid, parotid node. So I will show you the parotid gland, which we will talk about something important. So parotid, node. Now when that happens, eventually wherever they drain to whether anterior or posterior aspect, they will eventually drain into what we call the submandibular as well as the deep cervical lymph nodes. Okay, now for arterial supply, we are going to have actually two main supplies. Okay, we are going to have divisions which are going to come from the external carotid artery, then divisions which are also going to come from what we call the branches, a branch of internal carotid artery being the ophthalmic artery. So branches of the external carotid artery, which let me see if I can show you some of them. Branches from the external carotid artery, will actually include what we call the superficial temporal. So we are going to have what we call superficial temporal vein, artery, superficial temporal artery. So superficial temporal artery will actually give some supply to what we call, apart from the temporal area, will also come a bit anterior to supply some portions of the frontal area as well. So that is what we call superficial temporal artery. Then apart from this, we are also going to have what we call posterior auricular artery. Yes, this is the posterior auricular artery, also giving some branches to supply the skin or the area where it's behind what we call the ear. Actually posterior superior, yes, it's a bit superior to the ear. So that's what we are going to find. Then apart from that, we are also going to have what we call the occipital. So there's the occipital artery, also giving some supply to the occipital area of the scalp. So that is with the branches which are coming from what we call the external carotid artery. I'll look at the external carotid artery in no time, so that we try and get all these areas. Yes, apart from this, we're also going to have some branches from actually the internal carotid artery, and I told you it's going to be the ophthalmic artery, which will give two main branches. We are going to have the supra orbital artery, supraorbital artery, going through the orbital foramen or orbital notch, supraorbital notch. Then we're also going to have supratrochlear artery. Also giving artery. So it means that the supratrochlear artery will actually give supply to what we call the anteromedial portion. Then for the anterolateral portion will be by the supraorbital artery. Okay, so that's how the supply is going to be. Now for the venous drainage, there are two groups. We have the superficial group, and of course we have the deep group. For the superficial group, their names are just opposite to what we have for the arteries, for the named arteries. So for instance, we are going to have what we call superficial temporal vein, posterior auricular vein, occipital vein, as well as of course superior supraorbital vein, supratrochlear veins, okay, being but they are not shown here, but of course they will accompany their veins. Then you also have the deep vein. Now the deep vein actually will form what we call a pterygoid plexus, okay, where it's also that's the pterygoid plexus, and to be found between the temporalis muscle and the lateral pterygoid muscle. Okay, there's the temporalis muscle, and then we have what we call lateral pterygoid muscle. In between them, we have what we call a pterygoid, plexus. Okay, and eventually this pterygoid plexus will actually drain into what we call the maxillary, vein. Maxillary vein. We will look at all those things, okay, in our later sections. Now, so that is mainly one thing that we are going to find. Now, for the innervation, for the nerve supply, mainly it will be going to be by what we call the trigeminal nerve and the cervical plexus of nerves. So with the trigeminal nerve, that's the cranial nerve 5. Now the cranial nerve 5 will give some cutaneous sensations, okay, the skin. So cutaneous sensations, okay, which the nerves will also just be the same. Yes, we are going to have what we call supraorbital, yes, supplying this area, okay, anterolateral. Then trochlear, okay, will supply the area anteromedially. Okay, so that's how they are going to give this kind of cutaneous sensation. Now, of course, one thing I have to know is that these supraorbital and of course supratrochlear nerves will actually be coming again from the ophthalmic division of the trigeminal nerve. Now the ophthalmic division is the V1 or the first branch of the trigeminal nerve. So that's one thing. Then of course we also have what we call zygomatico temporal. Of course with its name zygomatico temporal will be around this area, will supply the region around this area, the region where it's actually going to be anterior superior to the ear actually will be supplied by that one. Or you can talk about this area being the temple, the temple supplying this temple area. Then of course you also have what we call auriculotemporal nerve. Yes, if you talk about auriculotemporal, then again it's going to be around here, okay, which is actually going to be anterior superior to what we call the ear, the external acoustic meatus. So that's how it's going to actually relate to it. Now remember that this auriculotemporal will be a branch of what we call the mandibular division of the trigeminal nerve. Mandibular division of the trigeminal nerve. That's the third division. That's the V3. Then of course the zygomatico-temporal division will actually be coming from the second division. That's the maxillary nerve. Okay, now I told you that we are also going, apart from branches coming from what we call the trigeminal nerve through what we call the various divisions of the trigeminal nerve, we're also going to have what we call cervical nerves. So the cervical nerves, just to mention them, we have what we call the lesser occipital nerve. This lesser occipital nerve will actually originate from what we call anterior ramus of C2, anterior ramus of C2. So at the spinal cord level, okay, level C2 level, this emerging from this area will be C2, but sometimes C3 can also even contribute. But remember, it's going to be the anterior ramus of C2, but sometimes C3 can also supply it, and it's going to supply the skin posterior to, of course, the neck, so around the skin over here, which will be actually posterior to the ear, okay, posterior aspect of the ear, skin over here, okay, will also supply it around the neck area as well. Okay, now the next thing that we also see is the greater occipital nerve. Now for the greater occipital nerve, it will be coming from actually the posterior the posterior rami of C2 and C3. This time is C2 and C3 of the cervical plexus, and it's actually also going to supply the medial aspect of the skin, which is going to be posterior to the ear, as well as the skin over the angle of the mandible, the posterior auricular nerve. So that is one thing that we are going to see. Yes, even apart from this, now the next one which we are going to talk about is the great auricular nerve. Now the great auricular nerve will actually come from the anterior rami of C2 and C3. Remember that the lesser occipital was actually coming from anterior ramus of C2, sometimes C3 contributing. The greater auricular, greater occipital, also came from C3 and C2, but actually the posterior rami. Then we also have what we call the great auricular. Now for great auricular, it's going to come from the anterior rami of C2 and C3. Now if it is that, now what happens is that supplies the skin over the the ear area, posterior to the ear area again. Then actually over the angle of the mandible as well. It's also going to give some kind of supply over there. But importantly, one landmark that we also always use is going to be the parotid gland. So the great auricular, so you can simply say that it's going to supply the skin around the area where we have the parotid gland. Therefore, it means that if someone suffers from parotiditis, either viral parotiditis or parotitis, or mumps, then if there's pain, then it's because of the compression of the nerve by the inflamed parotid gland. So that is one thing that we have to actually know. So that is it. Now we also have what we call the third occipital, which will be supplying actually will arise from the posterior ramus of C3. Posterior ramus of C3 will be the third occipital, and to supply the skin of the inferior occipital region. So inferior occipital region, around here, which will be by what we call the third occipital nerve. So these are the things that we have to actually appreciate. Alright, ladies and gentlemen, I hope this tutorial was helpful. We hope to actually get to actually the real-time sections to see some of these structures actually. Thank you very much for your audience.